I'll be talking about Addison's disease. A little bit recap on the pituitary adrenal axis. The hypothalamus produces the corticotropic releasing hormone, which will stimulate the pituitary gland to secrete the adrenocorticotropic hormone, and this will stimulate the adrenal gland to produce the steroid hormone. So this is controlled by negative feedback from the increased level of the steroid hormone. Cortisol function as immunosuppression, anti-inflammatory, causes metabolic effect like weight gain, insulin resistance, causes skin thinning, osteoclastic activity of the bone, and osteoporosis, while the mineralocorticoid retains sodium and water and excrete in exchange with the potassium, and this will increase the blood pressure. However, sometimes there can be autoantibodies against the adrenal cortical mass, and also autoimmunity against the enzyme 21 hydroxylase. This will reduce the steroid hormones produced by the adrenal glands, like the androgens, the mineralocorticoid, and glucocorticoid. When the level is reduced, this will cause a positive feedback to the hypothalamus, and it increases the release of the CRH, corticotropic releasing hormone, which will cause the anterior pituitary gland to increase the adrenocorticotropic hormone, or ACTH. Sometimes it can also cause increase in prolactin level. So the causes for Addison's disease includes infection, exogenous thrombolytic agent like warfarin causing adrenal hemorrhage or adrenal infarction, and adrenal malignancy or metastasis, or infiltration into the adrenal gland like hemochromatosis or amyloidosis. It also can be caused by iatrogenic, like resection of the adrenal gland, or congenital adrenal hyperplasia, which presents with ambiguous genitalia, or external or medications that is used to reduce cortisol production in Cushing's syndrome, in Cushing's disease, like etomidate. As we know, primary adrenal insufficiency is Addison's disease, while the secondary adrenal insufficiency can be caused by hypothalamic or pituitary dysfunction. The risk factors for this Addison's disease includes female gender, adrenal corticotropic autoantibody, autoimmune disease, adrenal hemorrhage, infection like TB or meningococcal infection, or medication. So Addison's versus Cushing's. We can remember it as Addison A, absent steroid. So there's small, weak, and tan, which is hyperpigmented, and low blood pressure, low weight due to water loss, low temperature, which is cold intolerance, low hair, alopecia, low mood, depression, low energy, which is fatigue, low sodium, in which is below 135, and hypoglycemia, which is low glucose, and slow or absent periods, which is amenorrhea. But there will be a pigmentation, which is a bronze pigment, and also high potassium. So for Addison's, remember added pigmentation and potassium, decreased weight, which is water loss, and also decrease BP, hair, sugar, and energy. So there will be fatigue, alopecia, hypoglycemia, hypotension, and sodium loss, and also salt craving. While for Cushing's disease, remember Cush, in which in which C for cushion, there will be truncal obesity, moon face, buffalo hump. U for unusual hair growth, there will be hirsutism. Skin, there will be purple striae or butterfly mark. And high is for the sugar and blood pressure. For Cushing's, the patient will remember big. So big blood pressure, big blood glucose and sodium, big belly, which is truncal obesity, big face, which is moon face, big buffalo hump or fat pad, big hair like hirsutism, big stretch mark, which is purple striae, big red face, and big infection, which is slow wound healing. So the investigation that we can send for Addison's disease is we can measure the serum ACTH, which will be increased, while serum cortisol will be low, and we can check for the sodium, which will be low, potassium which will be high, and also urea will be high. This reflects the function of mineralocorticoids. We should also do a thyroid function test to rule out Graves' disease. Then we can do imaging like CT scan to look for any adrenal tumor or any adrenal hemorrhage, which can be detected via ultrasound. So another way is we can do synectin test. This test will assess the ability of the stimulated adrenal glands to mount hormonal response. We will give a synthetic ACTH and then we'll measure the cortisol level after 30 to 60 minutes. Normally, the adrenal will respond and the cortisol will be increased. So the level will be more than 450 to 550 nanomoles per liter at 30 minutes. So coming to the management, we should educate the patient to never miss a dose of the hormonal replacement therapy. We will give glucocorticoid replacement, which is the hydrocortisone, mineralocorticoid, which is the fluid growth cortisone, and also androgen replacement for the woman. If the patient suddenly stop taking this medication, this will cause adrenal crisis due to sudden drop of the glucocorticoid level. This is usually in a patient which receive a long-term hormonal therapy and suddenly stop taking the medication. In this patient, the exogenous glucocorticoid actually causes a negative feedback to the brain, which causes a much reduced ACTH level. So if we stop this medication suddenly, it will cause adrenal crisis in which there will be electrolyte imbalance like hyponatremia, hyperkalemia, hypoglycemia, dehydration, and also shock. In patients receiving the hormonal replacement therapy, we should also monitor for the side effect of the medications, like any secondary Cushing's symptoms or osteopenia, osteoporosis, and also the blood pressure, in which hypertension due to mineralocorticoid replacement. Other than that, we should also encourage the patient to wear a mobile bracelet so that people will know that about the condition. And also when the patient is unwell, we should increase the dose of glucocorticoid.